hydronephrosis with ultrasound, it's important that we differentiate hydronephrosis or dilatation of the collecting system from parapelvic cysts. We also need to look at the hydronephrotic portion of the kidney for visible debris or clot in the fluid. We then make an attempt to follow the ureter down to the bladder, looking for the point of obstruction or the source of the hydronephrosis. We can use color Doppler to look for ureteral jets, which helps us determine whether we have a partial obstruction or a complete obstruction of that ureter. And then we should consider whether pulse Doppler of the kidney, or RIs, will be useful in this particular patient. So get started with an example of a patient who came in at 30 weeks pregnant, and this woman had a fever, pyuria, and an elevated peripheral white cell count. And you can see on the image here that we have moderate to severe hydronephrosis. But in addition to the hydronephrosis, you can see echoes in the background of the collecting system and even a debris fluid level here in this dilated calyx and another debris fluid level here in this dilated calyx. Well, she was taken to the operating room and a stent was placed overnight, and the sonographer who was asked to image provided these images. And this is the image where she's pointing to what she felt was the stent seen here in the kidney. But I want you to appreciate that this is not the stent. It's not echogenic enough, it's not shadowing, and in addition, you still have a dilated collecting system full of debris. You don't see the anechoic portion because she's taken the picture through the part of the collecting system that has debris in it. So we did bring her back down to the department the next morning, and you can see that the stent was certainly well placed in the bladder. Notice all of the debris in the urine that's in the bladder, but here's the stent here, so that's fine. But when we look at the ureter, we can see the big distended ureter here running down the right flank, and inside the ureter, the curl of the ureteral stent. And the stent had gone into the ureter here and looped around to be stuck in the distal ureter. Still had hydroureter and still had hydronephrosis. Here's another patient who came in pregnant, again with right-sided flank pain. And we can see again moderate hydronephrosis of the right kidney. And when we looked transvaginally, we were able to identify a small stone in the distal right UVJ, looking like it's almost to the bladder, and with a little hydration, maybe it will slide right through. She felt much better the next morning, and it was presumed that she had passed the stone, and she was sent back down to the ultrasound department to make sure that the stone was gone and the hydronephrosis had resolved. But what we saw instead was persistence of this moderate hydronephrosis and a new fluid collection seen in the perinephric space here at the upper pole, all along the lateral aspect of the kidney and around the lower pole of the kidney. And transversely, we can see it all around the lower pole of the kidney. Indeed, when we follow that ureter down, all the way down to the bladder, we can see that the ureter is still distended, and at the distal UVJ, there's the 9mm stone still right where it was. So what had happened was, this is a ruptured fornix, and the pressure in that collecting system has now been relieved as the urine is now released into the perinephric space, and yet her obstruction has not resolved, and she will need something done about that stone. Well, so what are the roles for renal Doppler when we look at hydronephrosis? If in a patient with unilateral hydronephrosis, the RI is above 0.7, or there's a difference of 0.1 between the hydronephrotic kidney and the normal kidney, this suggests to us that there's obstruction present rather than dilatation. The question is whether RIs can even identify obstruction prior to the hydronephrosis even developing, but there's variable results in the literature about this. Well, how do we do renal Doppler? We sample multiple sites in each kidney. The standard site for measuring an RI is the interlobar artery. A normal RI is less than 0.7, and the RIs should be similar in right and left kidneys. Here's an example of a normal kidney. The color Doppler is on. It helps us identify the vessel that we're going to interrogate with the pulse Doppler. Sample volume is set here at the interlobar artery. We see a beautiful tracing with rapid systolic upstroke. Here's peak systole, here's end diastole, good diastolic flow throughout the cycle, and a normal RI of 0.53. Here's a patient where we see bilateral hydronephrosis, and notice in this patient, here's a stent. You can identify the stent. You see the parallel white lines. It's very echogenic, and it's sitting in the middle of the collecting system, something we did not see on that earlier patient. So here's a moderately dilated, moderately hydronephrotic right kidney, and again, moderate hydronephrosis on the left kidney. We see blunted calyces here. Here's the explanation. This is the post-void image of the bladder. The bladder is massively distended, almost 12 by 10 centimeters. Thick wall, trabeculations. Looking over to the right side, we can see a dilated right ureter. So there's a hydroureter here. There's a piece of the stent seen running up that ureter. And when we looked with color Doppler in the bladder, we were able to see urine coming out the end of the stent. So there was a little jet there. So we know that this patient is not completely obstructed. The stent is patent. So we put RIs on, and when we look at the RI on the right kidney, it's normal at 0.67. RI on the left kidney, normal at 0.64. This implies that this collecting system is dilated or distended, but not obstructed. A Foley catheter was placed in the bladder. The bladder is decompressed. You can see the thick-walled bladder being decompressed here. And look at the kidneys. The kidney hydronephrosis has resolved. The right kidney looks great. Left kidney almost resolved as well. So the hydronephrosis in this kidney was not actually obstructive hydronephrosis. It was dilated collecting system because there was nowhere for the urine to go due to that massively distended bladder. Here's another patient with hydronephrosis, moderate hydronephrosis, blunted calyces. On the transverse image, we can see the explanation, which is there's a mass just medial to the renal pelvis in the midline, along the IVC, para-aortic, and this turned out to be metastatic esophageal cancer. RIs in this patient elevated on the right side with the hydronephrosis at 0.83. This makes sense. This should be an obstructed kidney. It should be under pressure. But look at the left side. Here's the left-sided kidney, no hydronephrosis, elevated RI. This patient had underlying medical renal disease, abnormal RIs in both kidneys. So the elevated RI did not help us determine whether this was dilatation versus obstruction. Because again, just having a dilated renal collecting system does not mean that obstruction is the source. Here's another patient who came in with what looks like maybe some mild hydronephrosis. In this instance, when we turn the color Doppler on, we see that we're actually just looking at a big distended renal vein, and there's absolutely no hydronephrosis going on in this kidney. So this is pseudohydronephrosis, and certainly color Doppler is very useful when you think maybe you're just looking at the vessels. One point in one type of patient where Doppler with a dilated collecting system is very useful is patients who are pregnant. Mild to moderate hydronephrosis of pregnancy is extremely common. It is usually on the right side and usually asymptomatic. The etiology for this hydronephrosis is felt to be either mechanical or hormonal or a little bit of both. Either way, this is what it looks like. Here's the right kidney, sagittally. There's mild hydronephrosis on the right side. We measure RIs in this patient. They are completely normal at 0.57. This is hydronephrosis of pregnancy. No treatment necessary. Now, when we have a pregnant patient, it's important to realize that if the left kidney is larger than the right, if the right is severe rather than mild to moderate, if the patient's having acute pain, or if the RI of that kidney is not normal, now we're thinking there may be an obstructive process going on. And the most common obstructive process to see in a pregnant patient would be a stone. So the next thing to look for is ureteral jets. Now, in the third trimester, only 13% of ureters will identify spontaneous jets. So to increase the likelihood of finding a jet, what can be useful is to roll the mom to the right and then back to the left to get the fetal head off the distal ureter, and then you might be able to pick up a ureteral jet. When the fetal head is in the way and obscuring the distal UVJ, then a vaginal probe to look for a distal UVJ stone can be extremely useful. Here's a patient 25 weeks pregnant who presented with flank pain. And again, we have a normal right kidney. And remember, the left kidney should never be more dilated than the right. So here's some mild hydronephrosis on the left side. So we're concerned she has pain and she has hydronephrosis on the side that we're not expecting it. Well, down in the bladder, turn on the color Doppler, and you can see a beautiful jet from the left side. So we know that whatever's going on the left side, she's not completely obstructed, but she may be partially obstructed. And in this instance, when we put on the vaginal probe, we can see the stone here floating around right at the UVJ. So the ureter, with the vaginal probe, the ureter comes down from this direction, heading towards the bladder here, as we're aiming down posteriorly, and you can see the stone really just ready to pop into the bladder with a little bit of hydration. Another pregnant patient, 33 weeks, with, again, left-sided flank pain, and here's mild hydronephrosis of the left kidney. Doppler in this instance, again, is normal, suggests that there's nothing, that this could be physiologic and there's no total obstruction, but as we follow the left ureter down, there is a stone at the UVJ. So regardless of the normal Doppler appearance, we do have a distal ureteral stone contributing to this hydronephrosis. Well, maybe it'll help us determine dilatation versus obstruction if we put the Doppler on. An elevated RI, again, would suggest increased pressure or obstruction, while a normal RI might mean that you have a dilated collecting system that never did go back to normal after the obstruction was relieved, or that is chronically dilated due to reflux. In these patients, looking at the RI on the opposite side and looking for ureteral jets will be extremely useful. Here's a patient with severe hydronephrosis of the left kidney. It's an enlarged kidney at 13.7 and significant hydronephrosis. Post-void, absolutely no change in the appearance of this kidney. RIs in this patient on the left kidney, completely normal at 0.67, suggesting we're looking at a dilated collecting system rather than an obstructed collecting system. And indeed, this patient had chronic reflux, which was congenital on the left kidney and had been followed for years. Another use for Doppler, on this transverse image of the right kidney, we see the renal vein filling in, and then we see flow in the center of this large mass extending off the anterior aspect of the right kidney, which is our lead-in to renal masses. Renal masses are found in more than half of patients over the age of 50. At least one, over half the patients over 50 will have at least one mass in the kidney. Now, when we talk about masses, most of these quote-unquote masses will be cysts. However, remember that small lesions in high-risk patients are likely significant, and it's important that when we identify a mass in patients, particularly high-risk patients, that we categorize them as best we can. But the other thing to remember is that many sub-centimeter lesions are missed at ultrasound. Well, how do I know that? Well, this paper in 1996 compared ultrasound and CT for small lesions, and they divided this into different levels or different sizes for the lesion, and ignoring these 0 to 5 millimeter lesions, even the 5 to 10 millimeter lesions, ultrasound was only able to pick up 21%, whereas CT found 60%. In contrast, when you get up to 20 to 25 millimeters, where CT has 100%, anything above 15 millimeters, ultrasound is only at 60% for 15 to 20 millimeters, and 80% for 20 to 25 millimeters. But remember, this was done in 1996, and it's now 2015. And in 2015, our ultrasound equipment has improved markedly in the past 10 years. And here you can see this patient who has 1, 2, 3 sub-centimeter renal cysts in the lower pole. So I'm not sure those numbers are quite doing justice to the advances in sonographic equipment. Having said that, when we do see a mass, how do we decide what to do? Well, for over 25 years, radiologists have relied on Bosniak's categories of renal masses. Now, in Bosniak, these categories were created for the analysis of masses that are found at CT, not at ultrasound. So remember, this is an ultrasound talk. I'll be talking about Bosniak categories, but a true Bosniak category is assigned after CT. Well, what are these categories? Categories are simple cyst. Category 2 is a mildly complicated cyst. 2F is a category 2 cyst with some follow-up indicated. Category 3, indeterminate. And category 4, clearly malignant. So categories 1, 2, and 2F are considered benign. Categories 3 and 4 are surgical. Notice I don't say benign and malignant, but benign and surgical. Category 1, the simple cyst. This again is a benign lesion, extremely common, found in over 50% of patients over the age of 50. And ultrasound is diagnostic for these category 1 simple cysts. How do we make the diagnosis? We look for round or oval lesions which are completely anechoic, have a smooth, thin, nearly imperceptible wall, and clearly increased through transmission. So here's a Bosniak 1 lesion, well-defined, imperceptible wall, completely anechoic, and here's the through transmission of the sound wave, giving us increased acoustic enhancement posterior to the fluid component. A smaller lesion, this one is completely within the cortex. You can see the cortical surface of the kidney over the top, but still imperceptible wall, anechoic, and through transmission out the back, both simple cysts. A mildly complicated or category 2 lesion is a lesion that is mostly cystic but may have a thin septation or 2. The septation can be as thick as 2 millimeters, but there cannot be any nodularity to the septation. And the best place to examine for that is right where the septation meets the wall of the cyst. That's where you're going to see the first start of nodularity. There can be a small amount of calcification in the wall of these type 2 cysts, but it needs to be peripheral, septal, and thin. It cannot be clumps of calcifications. And again, the junction with the calcification against the wall of the cyst is the spot where you will see clumping if there's going to be clumping. Occasionally, we do see low-level internal echoes within the cysts. Sometimes it's due to artifact, other times it's proteinaceous debris or even hemorrhage. And because of these internal characteristics, we may need CT to confirm, particularly if the patient is a difficult scan sonographically. Here's a Bosniak 2 cyst. You can see that it's mostly simple. It's got an imperceptible wall. It's got good through transmission, but it also has a very fine, incomplete septation, just this single posterior septation. Then we can confidently call this a benign cyst, no additional workup necessary. Couple more Bosniak 2s, mostly simple cyst, but a little bit of wall irregularity here. Good through transmission. Same Bosniak 2 cyst, very small, but maybe a thin septation here, maybe a little irregularity there, but predominantly simple, good through transmission, no additional imaging required for either of these lesions. What about category 2F? These are cystic lesions that are most likely benign, but have something that makes them slightly suspicious in some category. This is not a category that can be assigned after an ultrasound. It must be assigned after CT and ultrasound have both looked at the lesion. This is a lesion that it would be nice to put into the benign category, but there's something about it that requires 1 more or 2 more or 3 more looks to know for sure what's going on. So we will recommend follow-up for these 2F lesions. Here are some 2F lesions at ultrasound. We can see it's a cystic lesion. It's got some septations in it. We think it's probably a complicated cyst, probably not a cystic tumor, but ultrasound cannot be your final decision maker here. This lesion has to go to CT and be categorized. Now, when it gets to CT, it's entirely possible that the CT scan will allow us to categorize it as a Bosniak 2 and no follow-up will be necessary. But from the ultrasound perspective, this lesion needs additional imaging. Another patient, a different lesion, requires additional imaging. Here's the mostly anechoic lesion, but the septation is a little bit thick at this corner and a little bit broad and thickened at this top corner. The through transmission is there, So we think it's probably a simple cyst, but I do have to require CT evaluation to move it either into the regular 2 or to keep it as a 2F. Now, a recent paper in Radiology in 2014 followed all the 2Fs at the institution for up to 6 years, and it turned out that almost 11% of these lesions turned out to be malignant. So this is not a category to be dismissed. The follow-up of the 2F is very important. Category 3, that's the indeterminate mass. These are lesions, mostly cystic lesions with thick nodular septations. Now, if there are more than 3 septations in a lesion, the terminology is no longer a complicated cyst, but it is now called a multiloculated cyst. The differential for a multiloculated lesion is renal cell carcinoma or multilocular cystic nephroma. These lesions have irregular margins, poor posterior enhancement, and once again, CT is critical with this category. Here's a Bosniak 3 seen at ultrasound. You can see a sagittal image of the right kidney, and in the lower pole, a complex cystic lesion. I do not see good through transmission. The septations are fuzzy and thickened. There may even be nodular component to these septations. This patient went to CT and then to surgery, and this was a renal cell carcinoma. Another Bosniak 3 lesion at ultrasound. Again, a large lesion here, mostly cystic, and there are some thin-walled portions and maybe some through transmission here, but there certainly is a complexity to the posterior aspect of this lesion that ultrasound cannot pass as benign. Patient needs to go to CT. CT showed that it was an indeterminate lesion. Surgery showed a multilocular cystic nephroma. Now, if after a CT scan evaluation, the lesion is still indeterminate, it becomes the job of the pathologist to tell you what the answer is. This is either with biopsy or with surgery. When is biopsy useful? Well, in one paper from the MGH in 2003, biopsy and follow-up of category 3 lesions allowed them to avoid open surgery in 39% of those patients. A similar paper, also of 2003 from the Brigham, recommended 3 useful situations for biopsy of an indeterminate lesion. Patients with a known primary, in which you might be considering metastatic disease. Patients in whom the lesion is non-resectable, for example, in a solitary kidney. Or in patients who are not surgical candidates, where potential medical therapies are being considered. Category 4 is the clearly malignant tumor. These are the renal cell carcinomas. This is a solid mass, typically distorting the margins of the kidney. Renal cell carcinomas are typically hypoechoic at ultrasound, but in some reports up to 40% could be echogenic. Calcifications or cystic changes are possible in these mostly solid lesions, and these can be very challenging to evaluate when the masses are small at ultrasound. Here's a classic Bosniak 4. You can see a large solid lesion expanding out the cortical surface and pushing in to the renal sinus. So a space-occupying solid mass, very suspicious sonographically for renal cell carcinoma, and indeed was a cancer. So what is the role of ultrasound when a renal mass is seen? One thing that ultrasound can help with is confirming whether a lesion seen at CT is cystic or solid. Ultrasound can assess the blood flow to the mass and to the surrounding vessels. We can determine when additional imaging is necessary in lesions that are found incidentally, and ultrasound can be used intraoperatively. So here's a patient who was scanned, had a CT scan without contrast material, and on the left kidney we can see this well-defined exophytic lesion, which is isoechoic to the kidney, and the concern was for a solid lesion versus a hyperdense cyst. Here's the corresponding ultrasound, and you can see exophytic from the left ovary with good through transmission, this anechoic lesion with imperceptible walls. Here it is here to show you a little better through transmission in the sagittal plane rather than the transverse plane. So we could quite confidently confirm that yes, indeed, this is a as CT describes a hyperdense cyst and ultrasound describes a benign category 1 cyst. What about a patient like this? So this patient had a 9-centimeter mass on the right kidney and an additional 4.5-centimeter mass solid lesion on the left kidney. Both of these, Bosniak 4, very worrisome. Additional imaging at the time of the ultrasound, here, this is the inferior vena cava running behind the sagittal right lobe of the liver. And instead of the IVC being anechoic, we can see that it's filled with solid appearing material, and indeed the IVC is expanded at the level of the renal veins. Adding color Doppler shows us that there is still some flow in the IVC, but that there's a large solid appearing component or structure here down at the level of the renal veins. Transverse image now of the right kidney and right renal vein coming into the IVC. We see that the vein is expanded and filled with solid material. The color Doppler does show us that there's a little bit of flow in the middle of the vein. Pulse Doppler right on that flow in the middle of the vein shows arterial flow, low resistance neovascularity, which confirms that there is tumor thrombus in the renal vein rather than bland thrombus. Here's a conundrum for us at sonography. This is an image of the kidney, and we have an echogenic mass that's coming out through the cortex here, triangular mass. Well, that brings to mind, when can we determine whether we're looking at an angiomyolipoma or a renal carcinoma? 1996 paper comparing the two found that angiomyolipomas were typically smaller, more brightly echogenic. Angiomyolipomas will have shadowing or attenuation of the sound, and that's from the fatty component of the tumor. We know that fat attenuates ultrasound, whereas the carcinomas will not have any post-mass attenuation. Carcinomas are more likely to have a hypoechoic rim and cystic changes in the center when compared to an angiomyolipoma. Here's two examples of echogenic renal masses. In the patient here, we see at the inferior aspect of the left kidney a big echogenic mass. It's quite echogenic, it's very bright, it's well defined, except when you try to find the back of it, you can't tell. You can't tell where this lesion ends. And that's because as the sound wave comes in, the sound is absorbed by the fat in this angiomyolipoma, and you do not have enough sound wave in the back to give you the posterior aspect of the mass. In contrast, in this patient, we very clearly see the back of this smaller echogenic mass, maybe not quite as bright. This patient has an angiomyolipoma. This patient has an echogenic renal cell carcinoma. Well, can we really tell them apart? Nope, there's the answer. After looking at that last case, I hope you were saying, boy, I could not tell. We better get a CT. So we CT every lesion that measures over a centimeter to confirm the presence of fat and confirm that we're looking at an angiomyolipoma. Smaller lesions can be followed with ultrasound, Q6 months or once a year. And then when they have not been shown to grow, the follow-up can stop, particularly in patients who are the classic presentation for an angiomyolipoma, so a middle-aged to older woman who has a sub-centimeter, well-defined, bright echogenic lesion in the kidney probably does not require follow-up. Other categories of patients would require follow-up. So here's the typical patient that we do not really require follow-up for, 55 years old, female, well-defined echogenic lesion, only 7 to 8 millimeters in the cortex of the right kidney. In contrast, this patient has an echogenic lesion bulging the surface of the kidney. He was post-cardiac transplant, and this is an echogenic renal cell carcinoma. Another patient with an echogenic renal mass. In this case, you can see the hypoechoic rim around the outside. It's a little bit heterogeneous, maybe with some cystic areas, quite a bit of blood flow around the mass. This was an incidental finding in a patient that we were scanning for chronic hepatitis, but clearly not a convincing angiomyolipoma. Off to CT, category 4, went to surgery, and this was an oncocytoma. Another patient who presented with an echogenic mass in the kidney. not quite as bright as the echogenic sinus fat. Measures about 1.2 centimeters. Also, this was a 38-year-old man. So for 3 reasons, it's not bright enough, it's a little bit above our 1 centimeter cutoff, and it's a 38-year-old man. They just don't get angiomyolipomas. This patient, a CT scan is indicated in this patient to confirm what we're thinking, which is that, oh, well, it looks like maybe he does have an angiomyolipoma, even though he's not the typical patient. The CT scan was not done. It was read as an angiomyolipoma. Follow-up 3 years later, the patient had a large heterogeneous mass in the kidney, which was renal cell carcinoma. So you have to be very careful with patients who do not fit the category and lesions that do not clearly fit the rules for angiomyolipomas. When a mass is found at ultrasound, it's important that we complete the workup by looking at the renal vein, the inferior vena cava, and the opposite kidney. It's critical for the radiologist to know what the patient's history is. Is there fever? Was there trauma? Is there a known primary somewhere else in the body? Remember that ultrasound is diagnostic for simple cysts, but just about everything else is going to need either a CT or an MR, and then possibly a biopsy, with the exception being those little tiny AMLs and columns of Bertin. Here's another little tiny AML. This, in the correct patient, can be safely followed with ultrasound. In contrast, this lesion, about 1 centimeter in size, it's exophytic off the kidney, but it is not anechoic. Maybe or maybe not has through transmission, but this is not something we can dismiss at ultrasound. This lesion needs to be either followed with ultrasound until it grows, or CT or MR to further characterize. Just a few last cases. Here's a 32-year-old who came in. A 32-year-old woman, we found this 2.7 centimeter, very subtle lesion in this kidney, pretty isoechoic to the cortex. It's got a little rim around it, so we're not really convinced that this is an angiomyolipoma. It's not bright enough, and it shouldn't have that well-defined rim. And here's the color around the outside at this time. Well, she was sent for a CT, did not undergo the CT, was lost to follow-up, came back into care 14 months later. She's now 29 weeks pregnant, and repeat imaging shows, again, this slightly hyperechoic mass in the left kidney cortex. And at 29 weeks pregnant, the decision was to wait, and she waited until she was postpartum and had the surgery on this kidney in May of 2005, and this was a metanephric adenoma. Another patient who came in with a history of a left nephrectomy for renal cell carcinoma and a history of breast cancer. Outside MRI suggested that there may be a right kidney mass. It was done to look for metastatic disease to the liver. Took a long time, but eventually we decided that there really is a very subtle echogenic lesion, well defined in this right kidney. I'll show you the transverse clip. It's very hard to know transversely whether that was a real lesion. Here's the color Doppler of the area. A little bit of help showing us this rounded area right here. Again, this is a solitary kidney. It's a very small, very subtle lesion, but it was confirmed with MR and on this ultrasound, and this patient did have surgery, and this was a small renal cell carcinoma. One thing to remember, as this is a different patient, but this is a useful thing that may have been useful in that previous patient, we can come to the operating room and do ultrasound of the kidney. This is an ultrasound with the probe directly on the surface of the kidney to identify this 1 centimeter or just above 1 centimeter subtle lesion, solid lesion within the kidney. You could see the blood flow around it, and this was localization of this small renal cancer to allow a partial nephrectomy with clean margins.